I think that the main reason is the misconception that heart failure is simple and is something that anyone can approach. And I think that unfortunately we have not yet been able to effectively convey the notion that heart failure is not simple, is a very complex issue, and it requires special knowledge. One of the slides I'm going to show today goes back to the recommendation for training in heart failure, and the American College of Cardiology has actually defined 3 levels of training: level 1, level 2, and level 3. And what I'm showing is that 67% of level 1 requires at least 24 months. 100% of level 2 requires additional rotations within a regular 3-year cardiology fellowship, and 100% of level 3 cannot be accomplished in a regular cardiology fellowship, but it requires an additional year of heart failure training. As the number is increasing, so the American Board of Internal Medicine recognized the subspecialty which is called Advanced Heart Failure and Transplant Cardiology specialty. We had our first board exam in 2010, and that was taken by approximately 250 physicians, and we had the exam every 2 years since then. And we had a similar number, so we're now approaching over 800 physicians. And beginning with the exam that we have in 2016, there is no longer a grandfather contingent. So the doctors that will take the 2016 exam are all physicians that have had a 3-year cardiology fellowship plus and 1 year of specialized heart failure training. That's the challenge, but also opportunity that we have. Obviously, there cannot be enough heart failure specialists to take care of all the heart failure patients. But what we need to strengthen is the collaboration between heart failure specialists, general cardiologists, and primary care physician. We need to really build models of collaboration that are effective. The other approach that may help this deficiency of heart failure physicians is new technology that is really emerging, and some of which is now clinically available. And that is the ability of remote monitoring of these patients. We have a pulmonary artery pressure monitor, and when we implant that in a patient, we can read their pulmonary artery pressure values on a daily basis, and we can adjust medications based on the values, so that allows you also to reach a larger number of patients. I don't think we can afford to keep doing what we are doing. As I said, I think we need to create models where there is consistent collaboration with other physicians that see the patient. These In a way, we have an even bigger challenge now, because what happens, for example, for a patient that gets admitted for acutely decompensated heart failure, due to the time and financial constraints, their own primary care physician no longer attends them in the hospital. They are transferred to the care of hospitalists. So at discharge, there is further breakdown in the continuity of care. So I think we need to create ways to fill those gaps. One way that we are trying, and I believe successfully so, to fill that gap is the creation of dedicated clinics that are staffed by advanced practice nurses, and the patients are referred to them both by us, but also in many cases by primary care physicians, so or general cardiologists, so that the advanced practice nurses and the nurses that staff the clinic function literally as a liaison between the primary care physician and the cardiologist, and that way we can reach a much larger number of patients.